Welcome back, everyone, to Research Works podcast here at EACD and IAACD in Heidelberg 2025. And my guest during this morning tea break, as you'll hear the hustle behind me, is Professor Diane Damiano from NIH in the US. Thank you so much for being here, Diane.
Certainly. My pleasure.
I've been wanting to speak with you quite some time because I love hearing your thoughts and your views on areas that are being researched quite heavily at the moment. And I noticed that you were chairing a session on intensive therapy yesterday. And I thought, I want to hear your thoughts about the current state of the research and your thoughts about intensive therapy. Maybe we should start with defining intensive therapy. That might be a good place to start. How do we define that?
Intensive therapy to me just means in a very concentrated period of time, you spend many hours, typically every day for several weeks, doing some type of training.
Right.
With some specific goal, whether it's upper limb, upper and lower limb.
Yep. Yeah. Fantastic. And I suppose yesterday within the session that you were chairing, there was a lot of work being done, particularly around habitul. Is that correct?
Yes.
Tell me a little bit about what you thought about all of that.
Yeah, several of the studies were on habitul. They weren't done by, I don't think any of them were done. Maybe one was done by the original group. Others were done with people in Australia, group in Australia, and they presented several studies.
Yes.
And they were trying different ages, they were trying different intensities or different dosages, and also looking at who were the best responders to the therapy.
Right. And what are the findings there so far?
Yeah, so the interesting thing that I noticed is one of the things is that the results were not as powerful as the original studies. So I think that people were trying to understand that. And I think what I was thinking while I was listening to this is that the lessons we learned from constraint-induced movement therapy were that we needed to do an intensive dose, usually at least 60 to 90 hours total dose. And then the effects would wear off if we didn't do some type of transfer package or some type of home program. And I feel like these papers were exploring some of these same messages that I think are pretty clear, can be generalized across intensive training. That we know that we probably need this certain dose. We know we need to practice this in the home, or the children need to use it in some form, or it is going to fade, at least fade, if not.
Yeah, because that's quite a high dose to commit to. If it means the outcomes or the gains that were obtained during that program start to dissipate.
Right.
So the idea, I suppose, of doing more translation, home visits to support that.
Right.
How do you think that could look practically for a family who are wanting to engage in these intensive therapies? Do they need to do them multiple times a year? What could that look like?
Yeah, I mean, obviously there are families that are very interested in the intensive therapies. Children often do make big gains, bigger than they would see on, like, if you have therapy, a couple times a week for a long period of time. The gains are much more incremental, right?
Yeah.
I think what people don't appreciate, though, is that there's two things that are happening in an intensive therapy, and one's a motor learning component, and one's a strengthening component, and how you train for each of those is actually very different.
Absolutely.
So I think, what happens in intensive therapy, I think you get a lot of, probably more of the motor learning gains, which you would think would be maintained, but again, you still have to keep practicing that. And then the strength gains might increase a little bit, but then they would drop off right away as soon as you stop doing something physically intensive. So I think, and then I knew a lot of families that would do intensive and they would be very upset when their children started regressing. And so I've always worried about that. So I think, maybe we need more studies, and I'm trying to think of which ones I can remember about where you took the same dose, but you spread it over a longer period of time.
Sure.
Is that something that would be more sustainable? I don't know that answer. I don't remember that answer.
Yeah.
But I think total dose is total dose, and it doesn't have to be so concentrated. It can be spread out more. So maybe that's a better message, but
rather than just a lot of hours in just 2 weeks.
And the other message I think it's come across in habitul that I've heard other people talk about is that originally they want to keep it, sometimes when you do studies, you want to keep it pure. So you want to just be able to measure what you're controlling, which is the exactly what's happening when they come to the camp or whatever they're doing.
Yeah.
And then not to sort of affect that by having stuff done at home, which you can't measure as well. But I think that the lesson there is you have to do it at home. You
Yes.
have to somehow transfer it to home because otherwise it doesn't easily generalize unless
Absolutely.
you really work towards that goal to get it to the homes.
Yeah.
And then it doesn't, stay. So
That's an interesting point because I suppose that's the whole idea of, implementation science is another one of those buzzwords that have come out in research. And we have always, at the heart of research, you think about implementation. But I suppose from a pure science perspective, like you just said, it's 2 weeks of that real intensive practice. But the reality of what that would look like is 2 weeks might be really tricky to do. And you're not really seeing what it looks like at home. So from maybe designing studies with that implementation in mind might be more reflective. But then there'll be a lot of factors that you can't control for, I suppose.
Right.
What are your thoughts on that?
No, I think what I do like about intensive therapy is if you need a jump start, if you sort of need your child has been going through regular therapy, you really feel like you're kind of not making any progress, you're not, you've sort of gotten to a certain plateau. I think at that point, if you did something intensive and you do see your child changing, I think that sort of gives you a lot of motivation to keep going. And sometimes you want to do it during the summer, which works well with kids.
Yeah.
And a lot of these programs are in the summer.
Yeah.
So I think for families, it is workable in some ways. As much as, we ask a lot of parents these days. And so I think you do worry about that a little bit. So it is kind of nice for parents to have their child go off to a camp and be with other kids and then also work hard in a fun environment. So I think that from many other standpoints, it's probably a positive thing.
Sure. Yeah.
The not positive thing is what happens after and do we get to maintain those gains or do we have to keep redoing this?
Yeah.
Or is there a better model where we do something intensively to train someone and then spend more time trying to figure out how they can incorporate this in their everyday life.
Of course. Is there anything to do with possibly with outcome measures that we're using? Are we picking the right outcome measures?
So it depends, obviously you have a goal, you want to know from a mechanistic standpoint, how is it working and why is it working? So I do think we need to measure at the body structure and the functional levels.
Yeah.
I think, of course, a lot of these, and even, I noticed this in the session where they did measure it was a group setting with adolescents. And I thought they didn't talk about the participation outcomes. I'm thinking the biggest outcome of that was probably the adolescents being together and spending time together. So and they didn't measure that. So I think obviously we have to measure at different levels. We have good outcome measures. And I was kind of laughing because I feel like anytime something doesn't work, people are like, well, maybe you didn't use the right outcome. Like, how many outcomes do you want to try?
And that's the thing, right? When you look at a lot of these measures, you see a whole list of primary and secondary, and we're measuring a lot across the entire ICF, it seems.
Exactly.
And these poor parents sometimes have many questionnaires to complete.
Right.
So it's good to sometimes go, okay, no, the outcome measures are good. What we're looking right now is about the actual intervention itself.
Right.
And how that can be fine-tuned. Are there any other intensive models out there that you've seen? Because obviously we've heard a lot about habitual. That's a big area, I suppose, of research that's being presented. Do you, to your knowledge, know of any other models?
It's very similar to the constraint and then the bimanual training. It's all very similar.
Yeah.
Conductive ed was a very similar thing. The Adele Suit programs. There's been lots of intensive programs. And what I did think of many years ago when I was working at WashU in St. Louis is that a lot of our families were doing that. And I thought, so obviously doing things that weren't as evidence-based.
Right.
So it's good that we have more evidence-based interventions now, but obviously parents really want it. So I'm spent some time trying to think of that.
Yeah.
But interestingly, what I really believe works, and I try to tell families this, but the message is not as sexy, is that is that when you have cerebral palsy, you have a physical disability, and if you want to improve your mobility or your hand function, it's a lifelong. It's a lifelong project. It is like I tell them, you're training like an Olympic athlete.
Yeah.
It's going to take a lot of training. It's got to be at the right level. It's got to be individualized to your child and sort of where they are at this point in their, it has to be related to their potential. You can't, try to do things that would be not achievable for that child.
Yeah.
And it's not a sexy message because it's like you just need to keep training.
Keep working. Yeah. And that consistency, which is required.
The consistency is really good. And what we do know is that we know from I learned this from other rehab conditions like spinal cord injury, where things like strength training really accumulated over time. The gains from that, because you needed to get to a certain percentage of your strength to be able to use it in certain ways.
Yeah.
And I think obviously motor learning, we know you need lots of practice, and we know it needs to be more consistent.
Yes.
And so I feel like the message from intensive therapies I think it's good to say, let's do a boost, and then let's try to keep that somehow. Let's have a plan to keep that.
Yeah.
And not have the parents feel the pressure that I need to keep spending money to do that. Because a lot of these things, one of the studies was on cost effectiveness. And it found out, which is interesting, that this was more efficient, but it was more expensive than traditional therapies.
Yeah.
And then one of the other studies, interestingly, said that it was in Australia, and they compared it to usual care in Australia, and which was not as intensive, but it ended up being the same total hours. But what they found out is that there was very little difference between the groups. And again, because the level of therapy in Australia has improved so much.
Yes.
So
that's true.
Before, if you were doing something that was almost nothing, you can do almost anything and it's going to be better than that.
That's right. And it makes it very difficult to control. I know that's something we've spoken a lot about with Australian colleagues, is doing an RCT has been more challenging because to withhold is not really possible, not like how it was. And it's better now though, but the studies become much more challenging.
Yeah, a lot of people do the wait list controls, which I actually think are the most effective controls. If you're except for when you get to early intervention, unfortunately, of course, we need controls for early intervention. It's hard to wait list at that point.
Yeah, that's right.
I mean, you almost have to, and that, like the NIH in the trials, they really require you to have some kind of control group. So, I mean, children, if they are receiving early intervention, then you've got your control group. But if they're not, you have to do something.
Yeah, that's right.
So it's a little tricky.
Can I circle back to a point that you made before? I've been percolating that thought. When you do an intensive training, you are really looking at the two streams. There's the motor learning and the strengthening.
Right.
It almost feels like we need to be very specific about thinking about what the goal of what we're trying to do is. Is it both or is it one or the other? Because they're different. Can you help me tease that out a little bit?
No, they are very different, and that, I think that's also the confusion when we're doing intensive training. We are doing a lot, like in the habitual, there's a lot of different activities. And so and when you have a lot of activities, you don't really know which are the most effective.
Sure.
We know that intensive loading is important for strengthening. We know in the upper limbs, maybe strengthening is not as big of a deal, but that really doing that fine motor intensive practice is a bigger deal. Yeah, so I think it's important to sort of say, it's probably important to assess that child before, and see what are the limiting factors. Often, if you're not strong enough, it masks good motor control.
That's right.
So you have to really, if you understand each child, maybe you can tailor the program more.
Sure.
To saying this child's pretty strong, but now we need to really work on, practicing their coordination skills.
Sure. Yeah, and it's almost a different strategy as well, because strengthening does have loading, rest and recovery. Range of motion, inner, outer, middle. I feel like we need to be very specific if we're looking for strength base as well, right?
That's right. And so like habitual, if you're doing strengthening activities every day, we're told not to do that, right?
That's right.
So maybe an every other day model would be better for that if you're doing intensive loading and things like that.
Sure.
Because I think the lower extremity, it's an effortful program.
Absolutely.
For sure.
Yeah, absolutely.
And it probably does a lot of at least lower limb strengthening.
Yeah. And it'd be an interesting thing. I mean, anyone who has just regained a desire to get fit and they go to the gym one day and they are very enthusiastic on day one, and by day two, they're not able to move very well. So it's relevant to all of us to think about what loading looks like, and it is different for our kids and what that load will look like for them in terms of planning. What do you think the future of research in this area could or should look like based on what you've seen so far?
Again, I have a couple biases. The one bias, I don't like having names to things, unfortunately. So Habiteel has been something everybody needs to do Habiteel. And like, it's intensive upper and lower limb training.
Yeah.
And I don't know why we can't just say, I like to get back to basic principles. Like we're talking, okay, motor learning principles. What do we do here? What do we need to do for that? Strengthening principles. And then if we want to do intensive training, does it need to have a special name? I mean, I think it's really wonderful that she put together a package of these different exercises that did make a big difference. I think it's wonderful.
Yeah.
But I feel that and Habiteel is not so bad because it really does say upper and lower extremities. It sort of says what it is.
Yeah.
But I don't want people to feel like if they don't get Habiteel in their community, the parents
then they haven't done it.
They have nothing. They're like, what's wrong with my community? I don't have Habiteel. Yeah. It's like the deli suit. They didn't have the deli suit, then they needed to travel to the deli suit places. So like that worries me too, because I like things to be community based in the homes. And then I think the comparison is let's do an adaptive sports program and see how different are those outcomes from something that we call as more intensive therapy type of thing.
Yeah, right.
So the future of the field. So, I mean, obviously there's a lot of research, which is great. I think refining what works and what doesn't work, really finding the ingredients, what are the specific things, really being sure, like you're saying, of the goals of, okay, this is our motor learning goal to get this much better jerk coordination. This is our strengthening goal. And then seeing maybe even by measuring those two different outcomes, then seeing, maybe people that do more strengthening or maybe for that kid, that was the ingredient that should be continued more.
Yeah, I like that because otherwise there's a lot in there. Right. You can't tease it apart. What are the elements contributing to the other? And if we keep testing the same thing, we're probably going to get the same kind of results in a way, which may not be what we're looking for.
Right.
I am thoughtful we've talked about what works, but you can do a lot of intensive therapy of ingredients that don't work. And I suppose that's why there are brands. I'm with you. I think the problem with brands or names is that you basically put together camps of people that are dedicated, and we become a little bit tribal in a way, like I love this only and I can't see anything else. Right. And it's the same in the ingredients that we know don't really work, the non-evidence sort of based interventions. Can you help us to sort of tease that out a bit? Because I suppose if we are going away from names and we need to look for ingredients, what are the ingredients that we should eliminate in our toolkit, I suppose?
Yeah. I mean, I think, I've sort of put it down to a few things. The one thing is that effort needs to be there, and the effort needs to be exerted by the child. So anytime that this is the therapies where it looks like the kids are doing something, but it's really the therapist doing something or a machine doing something.
Yes.
That's not getting the kid. The child needs to be working hard.
Yes.
And they also need to be engaged. I think that's really important. Since children have to do so much practice and training, it should be fun and engaging.
Yeah.
And so that's an important ingredient. And the third thing is, but they did talk about in this session, which I like, but it's really important, are errors. The children need to perceive their own errors.
Yeah.
There was a talk on feedback and us telling people whether they were doing a good job or not. But to me, it feels like you have to ask the child when they try to do something and it didn't work. Okay, let's look at that a little bit. And what do you think? Why didn't that work? What do you think happened? What do you think you did or
it's
didn't
the co-op
do there?
Approach, really, isn't it?
Exactly.
Yeah.
Exactly.
Yeah.
To have them figure that out.
Yeah.
And then say, okay, well, let's try that. They came up with a strategy. Okay,
Beautiful.
Let's try that now.
Yeah.
So, but there's a lot of the things that seem to work from a therapy standpoint. These are they feel like minor tweaks on things. Like, how do you really measure the effects of that? It's a little bit tricky.
Sure. Yeah. final thing, I suppose, is reflexes. I feel like reflexes are still part of vocabulary, and reflex, I hesitate to say reflex integration because I think that was a brand in itself, like how reflexes can be integrated. And the reason, I mean, what I see a lot on social media, which is sometimes I go on there and once I look at one account, the algorithm just keeps showing me more things. And I see people talk a lot about how reflexes are a big reason why children can't do voluntary motor control. Where are we with that? I think it's worthwhile having some clarity in that space because I think people spend a lot of time then just trying to integrate reflexes.
I think, when you're passively manipulating someone to stimulate something and it may look like they're doing a movement or doing something differently, you're doing something very different to that person. So I think my view of reflexes from a neurophysiological standpoint, which is, things I learned a lot when I was, in graduate school, but what we know is that that voluntary movement and reflexes coexist in everyone.
Yeah.
And these things are at different levels, basically levels of not levels of the brain, but at the nervous system. So for example, we have eye reflexes and they come in when we absolutely need them, but we have the voluntary control overrides a lot of these things, right?
Yes.
So the real goal is the reflexes are there and they're underlying there. They're sort of like the final straw if something's breaking down. But I think that what you really need is the voluntary control.
Yeah.
So, because that's going to produce the type of movement that you want.
Right. And that's where we need to spend our
the
time.
Functional movement.
Yeah.
Yeah. The reflexes they're not meant to be functional. Training them does not, improve function. It's different when you're talking about reflexes versus like responses, like vestibular responses. Like some things are obviously very important. We need to have those.
Yes.
But purely reflexive behaviors, trying to stimulate those, we may strengthen the reflex. Like we can strengthen H reflexes, but we don't change the voluntary behavior.
Yeah.
Which is really our goal.
Yeah. That's really important to note. Final question. What's been the highlight of the conference for you so far?
The highlight was the first keynote with the person who is doing all the work with Rett syndrome, and it was just fascinating. But it kind of made me jealous because she did early training with children with Rett before they had symptoms, and she found profound changes. And I feel like I don't feel like our early stuff is not getting profound changes. I was kind of like, what are we missing? Like we have a lot of, we can help children have better lives for sure and participate more and gain function and all those good things. But I think, again, this is why parents want more because it's not dramatic.
Yeah.
None of it's dramatic yet. And I just am jealous when it is dramatic and thinking, what are we missing? What aren't we doing?
It's almost that, I understand. I feel like there's this missing, you almost have this gut feeling, there's this missing link that we just haven't quite unlocked yet.
Right,
and
I agree.
We're all kind of on the fringes trying to get to it, which is why we need to be so much more efficient with how we do research so that we can cut through and go, okay, all right, that's done now. That's done now. Let's be a bit ruthless. And I just feel like there is something. And I can't.
I know.
Maybe it's optimism, but I'd rather have that optimism than not.
That's right.
Well, thank you so much for speaking to me today, Diane. It's
nice
lovely just to chat about intensive therapy, an area that I'm really passionate about and an area that a lot of families are very interested about as well. So it was just wonderful to speak with you. Thank you.
Thank you.
To all of our listeners, I hope you really enjoyed that as well. There's so much more to come, so stay tuned on Research Works Podcast. Bye.